There is a business that pays highly trained people to wait for disasters. It keeps operating rooms empty but ready, stores blood that may never be used, maintains backup power for failures that may never happen, and staffs an emergency department through the quietest hours of the night. It cannot choose when its most urgent customers arrive. In many cases, it cannot even decide what price it will ultimately be paid. From the street, it may look like one of the safest and most important assets in a city. From the balance sheet, it can lose money while every bed is needed. That business is a hospital. And if you decide to own one, you are not simply buying a building where doctors treat patients. You are buying a promise that an entire medical system will be ready before anyone knows exactly who will need it, what will be wrong with them, or who will pay the bill. That promise is the real product. A factory can reduce production when orders slow down. A hotel can close a floor during the quiet season. A hospital cannot send the night shift home because the emergency room has been empty for 20 minutes. The next patient may need a scan, a surgeon, an operating room, blood, oxygen, and an intensive care bed immediately. So the first economic fact is also the strangest one. A hospital spends money before demand appears. The lights, ventilation, sterilization systems, pharmacy, laboratory, imaging equipment, computer network, security, and clinical staff must all be available whether the next hour brings one patient or 50. Much of the cost is fixed in the short term. Revenue is not. This is why the price of the property tells you surprisingly little about the value of the business. There is no honest universal rule that a hospital costs a certain amount for every bed. Recent public projects show how wide the range can be. A new acute care project in Texas, designed for an initial 62 beds, carried an estimated construction cost of about $171 million. A proposed 50-bed hospital in South Carolina listed a total project cost of roughly $320 million. At the other extreme, a major new hospital tower at the University of California, Davis has a project budget of $3,750 million. Those facilities are not equivalent. Their locations, clinical services, building standards, equipment, and complexity are different. That is exactly the point. A bed is only the visible end of a much larger system. Behind it are medical gas lines, infection control, backup generators, elevators large enough for stretchers, medication storage, nurse stations, laboratories, information systems, and rooms designed around machines that may weigh several tons. Even replacing a magnetic resonance imaging scanner can require walls or ceilings to be opened and heavy cranes to move the magnet. Then comes regulation. As of early 2025, 35 states and the District of Columbia operated some form of Certificate of Need program. Depending on the state and the project, an owner may need approval before building a hospital, expanding capacity, or adding certain services. The purpose is to ask whether a community needs the additional capacity. But for an investor, it means capital can be committed long before approval is certain. Opening the doors is not enough either. To participate in Medicare and Medicaid, a hospital must satisfy federal health and safety requirements. Compliance can be evaluated by a state survey agency or through an accreditation program approved by the Centers for Medicare and Medicaid Services. Licenses, clinical standards, pharmacy controls, record keeping, emergency procedures, and quality systems are not optional decorations. They are part of the operating machinery. By the time the first patient arrives, the owner may already have spent hundreds of millions of dollars and accepted years of obligations. But construction is only the entrance fee. The largest continuing expense is labor. According to the American Hospital Association, labor accounted for about 56% of hospital expenses in 2024. That includes the people visible at the bedside and the much larger organization behind them: nurses, physicians employed by the hospital, pharmacists, technicians, therapists, cleaners, food service workers, security, billing specialists, information technology staff, and administrators. Hospitals do not merely need enough employees in total. They need the correct people on the correct shift with the correct credentials. A hospital cannot replace an intensive care nurse with an office employee because the building happens to be quiet. It cannot postpone an emergency operation until labor becomes cheaper. After payroll come drugs, disposable supplies, implants, oxygen, food, electricity, maintenance, insurance, and software. Some supplies expire even when they are never used. Some equipment requires service because a calendar date has arrived, not because the machine has earned enough revenue. Cash also moves through a hospital in an uncomfortable order. Employees are paid now. Vendors expect payment now. Electricity is consumed now. But patient revenue often arrives later, after coding, claim submission, review, negotiation, denial, correction, and collection. The number printed on a hospital bill is not the same as the cash that enters the bank account. One patient may be covered by a commercial insurer that negotiated its own rate. Another may be covered by Medicare, where many payment rules are set administratively. Another may be covered by Medicaid. Another may be uninsured or unable to pay the full amount. The medical team can perform nearly the same service, but the final payment can be very different. This is the payer mix, and it can determine whether two similar hospitals produce completely different financial results. The latest national data make that difference visible. For fiscal year 2024, the Medicare Payment Advisory Commission reported that urban hospitals had an aggregate all-payer operating margin of about 6.6%, while hospitals in rural, non-metropolitan areas averaged about 1.5%. For-profit hospitals averaged much higher operating margins than non-profit hospitals, although the result varied enormously from one institution to another. The same report found that the aggregate margin on traditional Medicare inpatient and outpatient services was negative 12.1%. That does not mean every Medicare patient creates a loss, or that every commercial patient creates a profit. It does show why the mix of contracts, patients, and services matters so much. Hospitals therefore operate as networks of internal subsidies. An emergency department provides access that the community depends on. Under federal law, most hospital emergency departments must provide an appropriate medical screening examination and stabilizing treatment for an emergency condition, regardless of the patient's ability to pay. That mission is essential, but it also creates a service line where demand is unpredictable and payment may be uncertain. Scheduled procedures are different. An orthopedic operation, cardiac intervention, cancer treatment, imaging study, or laboratory test can often be planned, staffed, coded, and reimbursed more predictably. Depending on the contract and the cost of the case, those services may generate the contribution that helps keep less profitable services available. The hospital is not earning money from one universal product. It is balancing dozens of businesses inside one building. Now imagine an otherwise healthy hospital with a 5% operating margin. For every $100 of operating revenue, only $5 remain after operating expenses. If net revenue falls by 5% while payroll, utilities, insurance, and minimum staffing barely change, the profit can disappear. Nothing dramatic has to happen. The building does not need to burn down. Patient volume can shift. A major insurer can renegotiate a contract. More patients can arrive under lower-paying programs. A shortage can force the hospital to use expensive temporary staff. A profitable surgeon can move to a competing system. A drug can become more expensive. Any one of those changes can move a hospital from expansion plans to a cash crisis. This explains why a cheap hospital can be one of the most expensive assets you ever buy. Suppose a rural hospital originally cost tens of millions of dollars to build, but the owner now wants to sell it for a fraction of that amount. The building is real. The operating rooms exist. Some equipment may still be useful. On paper, the discount appears enormous, but the seller is not giving away profitable demand. The seller may be transferring a fixed-cost system that serves too few patients, struggles to recruit clinical staff, and receives too little revenue from its payer mix. The United States Health Resources and Services Administration reports that 152 rural hospitals closed between 2010 and 2025. Research by the Government Accountability Office found that after rural closures, residents in affected service areas often had to travel about 20 miles farther for common hospital services, and farther still for some specialized care. The economic loss becomes a public access problem. That is why due diligence cannot stop at the condition of the roof or the age of the scanners. A serious buyer needs to know where patients come from, Which physicians generate admissions? How many procedures leave the area for competitors? How long claims remain unpaid? How much revenue comes from each payer? Which service lines produce contribution? How much maintenance has been deferred? And whether the hospital owns its real estate. That final question can change everything. Steward Health Care became one of the clearest modern examples. The company grew from a group of struggling community hospitals in Massachusetts into a national chain. Its expansion was helped by a sale-leaseback transaction. Hospital land and buildings were sold to Medical Properties Trust for a large upfront payment, and Steward then leased the same properties back. The transaction converted real estate into cash. It also converted buildings that Steward had controlled into long-term rent obligations. This can look attractive at the beginning. The operator receives capital without immediately closing the hospital. Investors can recover money. Expansion becomes possible. But rent joins payroll, supplies, insurance, and debt as another payment that arrives every month regardless of patient volume. By the time Steward filed for bankruptcy in May of 2024, congressional analyses described roughly $9 billion in liabilities, including about $6.6 billion in long-term lease obligations and almost $1 billion owed to vendors and suppliers. A Senate report described chronic understaffing, missing equipment, unpaid vendors, deteriorating facilities, and serious quality concerns at multiple Steward hospitals. The lesson is larger than one executive or one company. A hospital already has high fixed costs. Loading the operating company with rigid financial obligations removes the cushion it needs when reimbursement, volume, or labor conditions turn against it. Selling the building did not remove the cost of the building. It changed the name of the cost from ownership to rent and made the payment difficult to escape. That distinction matters because hospitals need financial slack. Some unused capacity is the ability to absorb an emergency. An empty intensive care bed, an available operating room, backup oxygen, spare equipment, and an extra trained employee may all look inefficient until the exact moment they become essential. An owner who removes every apparent inefficiency can improve the spreadsheet while weakening the hospital. So what would a genuinely attractive hospital look like? It would serve a stable or growing population. It would have physicians who want to practice there, enough nurses and technicians to staff its services, competitive insurance contracts, useful specialties, reliable outpatient demand, manageable debt, maintained equipment, and enough working capital to survive delays in reimbursement. Ideally, its most important buildings would not be burdened by rent that rises regardless of performance. Most importantly, its revenue would match its mission. A hospital that provides trauma care, maternity services, intensive care, and emergency access creates enormous value for a community. But social value does not automatically become cash. Someone must pay enough to preserve the people, equipment, and capacity that create that value. This is the central paradox of hospital ownership. The building may be full of patients and still be financially weak. The invoices may be enormous and the collections disappointing. A hospital can be indispensable to the town and unattractive to a private buyer at the same time. You are not buying beds. You are buying a workforce, a network of physicians, contracts with payers, trust within a community, and the obligation to remain ready at 3 in the morning. The building is useful only when all of those pieces continue to work together. So if someone offers you a hospital at an unbelievable discount, the most important question is not how much the property once cost. It is why the system around that property can no longer pay for readiness. That answer tells you whether you found a bargain or whether you are about to inherit an emergency of your own. If you enjoy seeing how familiar institutions really work once the money begins moving, subscribe. There are many businesses that look simple from the outside. The most interesting ones are usually the machines hiding behind the front door.